Celiac disease is an autoimmune disease that occurs in genetically predisposed individuals due to exposure to gluten. The treatment is a gluten-free diet. However, the response to treatment is poor in up to 30% of people. Most of the lack of response is due to poor adherence to a gluten-free diet. And there are multiple reasons for this. It's a difficult diet. It can be costly. There can be poor availability of gluten-free products. And a lot of gluten-free products may not taste as good as wheat-based products.
With the exclusion of
with the exclusion of the wonderful food we're going to have today. Many patients and people feel that if they don't have symptoms when they consume gluten, even if they have celiac disease, it's okay. They can consume it. There's been problems with inadequate food and drug labeling, so that you often may not be aware that you're consuming gluten. And inadequate dietary counseling and follow-up. Lack of participation in support groups has been shown to correlate with poor adherence to gluten-free diets, and hence our interest in this meeting and supporting you as you support us. Inaccurate information is often obtained by patients, which can lead to confusion about the diet. Still, as Peter relates in his story, it's very difficult to dine out in restaurants often, although it seems to be getting somewhat better in certain areas. There's social pressures, peer and cultural, that makes it difficult. And transition to adolescence and inadequate medical follow-up after childhood, and that's one of the advantages of having a celiac center where we incorporate both pediatric and adult follow-up. This is from Peter Green and Christophe Cellier's review on celiac disease from the New England Medical Journal in 2007, and it's an algorithm for the workup of a patient with poorly responsive celiac disease. And I will just go through this as far as a way to approach how we evaluate a lot of patients that are seen at the center. The first step is to exclude other causes of villus atrophy and really clarify the diagnosis. This is an endoscopic and a histological picture of villus atrophy. The endoscopy, we see decreased folds, a little nodularity, and that's a picture of total villus atrophy. You don't see any villi. Villus atrophy can be caused by things other than celiac disease. As you can see, it's a pretty long list of other diagnoses which may be present and causing the pathological changes other than celiac disease. The way we classify typical histology for celiac disease is using a classification system, a Marsh classification system, in which there's a gradation from normal to increased intraepithelial lymphocytes, along then with the second classification, which is crypt hypertrophy, and then Marsh 3A, B, and C, which has varying degrees of villus atrophy. Even for Marsh 1, which is increased intraepithelial lymphocytes, there are other causes that need to be considered apart from celiac disease. These, and the list is a few, some more common than others. But again, you have to go back and reconsider the diagnosis if it was a Marsh 1 pathology on biopsy. One of the most important things that we do is when confirming the diagnosis is to review biopsies. If patients did not have their endoscopies done at Columbia at the center initially, we will ask patients to have the original slides sent here so that we can review them with our GI pathologists. The slides that we have reviewed in this fashion has resulted in a change in the diagnosis in between 20 to 25% of times where we will review it and not agree with the initial reading. And biopsies are difficult. There's difficulty in orientation, the way the slides are cut. So if you have a poorly oriented slide, it may look like someone has total villus atrophy when they don't. It's just the fashion and way in how the slide was made. The interpretation can be difficult too among pathologists. Not everyone, and I would say probably most often, the Marsh classification is not recorded on the pathology report. And we even here have tried to incorporate a more standardized pathological reading on interpretation of the slides, and where the quantification of intraepithelial lymphocytes and degree of villus atrophy can be more clearly noted. The number of biopsies have been found to be very important. Celiac disease is a patchy disease, and if you're only taking a couple of biopsies, you can miss it. Often when we get slides from other institutions, you can just look at the slide and you can see there's just two tiny little pieces, and you know right away that there's only a very, very poor representation of the duodenum is there. We did a recent study looking at using duodenal bulb biopsies, and in the past we never used to do this because among gastroenterologists it was thought that you don't really need to biopsy the bulb. Looking at adults' endoscopies, we found that doing duodenal bulb biopsies increased our yield of diagnosing celiac disease, again because of the patchy nature of disease. So we like to take at least between 4 to 6 biopsies from the second portion of the duodenum and now the bulb also. Another important aspect is who's reading your slides. In a lot of places, it may not be a dedicated GI pathologist who's reading the slides, and that, again, the experience in reading the slides makes a big difference. Where do serologies come into play? There are a number of serologies. There's panels from different labs, some more useful than others. Currently, the tissue transglutaminase IgA is the best screening test. The sensitivity is good, above 90%. The thing to be aware of is that you can have IgA deficiency, and it's more common in patients with celiac disease, 1 in 40 of people with celiac disease versus 1 in 400 in the population. In that case, you would need a tissue transglutaminase IgG test done. Now there's developed deamidated gliadin peptide test, which has also a very good sensitivity, and that's been incorporated into some of the panels by various labs. And so it's very important to know exactly what panel has been done and what was included on the panel. A lot of times I see patients that are referred, given the diagnosis of celiac disease, on the basis of an anti-gliadin IgG test and no biopsy and no other serologies. The role of genetic testing. The genetic testing is the most valuable, and it's nearly 100% negative predictive value. So we use it in order to exclude the diagnosis of celiac disease in situations where, one, it's a questionable diagnosis. So if the DQ2 and DQ8 are negative, then we're comfortable in saying that celiac disease is not what's going on. In patients who are already on a gluten-free diet, who never were initially evaluated, if they don't have the genes, then we can exclude celiac disease. And also in assessing relatives, as far as in families, who's going to need to be screened periodically in the future. If they don't have the genes, then we really don't need to worry about the development of celiac disease.